Okay, good afternoon. We are going to go ahead and get started. Thank you for joining us for part 2 of the childhood-led poisoning prevention trainings. This training is hosted by the Ohio Chapter American Academy of Pediatrics with support from the Ohio Department of Health. We want to thank ODH for their collaboration and want to recognize that content for this presentation was adapted from their Planet material and can be found on their website. For part 2, we'll be covering medical management resources and useful lead resources. Please use the chat box for questions throughout the training. We will answer these questions at the end. Please keep your lines muted and cameras off throughout the duration of the training. The presenters will turn their cameras on when they are speaking. If you have concerns or trouble viewing or can't hear us, please let us know. We will make these slides available at the end of the training, and a survey will be sent out for you to receive a certificate of participation. Now I'd like to take some time to talk about our quality improvement project that we are launching in July. This is for primary care practices. It is a 6-month project, and 25 MOC Part 4 points will be awarded. The global aim is for all children living in a high-risk zip code or with Medicaid insurance to have a lead test ordered and completed at their 12 and 24-month well visits. We'll offer practice coaching, creation of sustainable processes, and established protocol for lead testing follow-up. We'll have action period calls to discuss data and improve follow-up within your practice. We also have made great resources that are available for those that participate in the QI project, as well as those that are just interested in the resources overall. We have resources for families, a RAC card, and we also have a provider resource guide. We created an interactive lead prevention website where you can look up high-risk zip codes on the map, and all of the resources that I discussed previously are also on there as well, and you can find them at www.ohioaap.org/lead. We also have a link to the ODH's website as well as CDC's. And like I said before, if you have questions throughout the training, my name is Alex Miller, and I am the program manager for lead prevention with Ohio AAP. At this time, I would like to go ahead and introduce our speakers. Dr. Aparna Bol is the Ohio AAP Lead Prevention Medical Director, Associate Professor of Pediatrics, Case Western Reserve University School of Medicine, and she works at UH Rainbow Babies and Children's Hospital in Cleveland. Dr. Nicholas Newman will also be speaking. He is an assistant professor of pediatrics and environmental health, went to University of Cincinnati College of Medicine, the director of pediatric and environmental health and lead clinic, and works in Cincinnati Children's Hospital. At this time, I'll go ahead and pass it over to Dr. Bol, who will talk about our learning objectives and give a summary of part 1, just in case that was missed. And part 1 will also be available a recording in case you missed that as well.
Thank you, Alex. Good afternoon, I should say, everyone. Thanks for making the time to be with us for part 2 of this training. We reviewed in our first session the learning objectives, but just as a reminder, we aim to review the epidemiology of lead exposure in children, which we did in part 1, discuss the short-term and long-term implications of lead exposure, which we also have covered, and then we'll be reviewing anticipatory guidance, medical management guidelines around lead exposure, which is what we'll be focusing on today. Next slide, please. So again, a reminder of what we covered in part 1. We'll be focusing on medical management and response to positive lead tests in this session. Next slide, please. As Alex said, I'm just going to offer a brief recap from our first session for those who couldn't make it, and I certainly invite you to view the recording online if you would like to do that if you weren't able to attend. So as we discussed, children are exposed mostly to lead in Ohio through deteriorating paint and older housing. There are many other sources, and I'll review those quickly in a moment. Children are uniquely vulnerable to lead poisoning because of their physiology and their developmentally appropriate behaviors, and that there are a range of impacts of lead exposure on children and throughout the spectrum of life. But certainly in children, we are concerned about school failure, behavioral problems, and then lifelong issues like lost productivity and issues around criminal behavior. And as a reminder, Ohio law does require testing for high-risk children. And so we're going to dive into testing and response here in a moment. Next slide, please. Again, here are some common sources of lead exposure, but we know that 80% of children in Ohio are exposed through lead-based paint, dust, and chips in their homes and neighborhoods. But here are some other examples of exposures that we do see in children across the state as well. Next slide. The developmentally appropriate behaviors of children that make them more vulnerable to lead exposure is their hand-to-mouth behaviors, eating things that they find on the floor, exploring through oral, hand-to-mouth oral behaviors. Children who are iron deficient are at increased risk because they may exhibit pica behaviors, eating non-food items. And then in older children, just a reminder that developmental delay and persistent hand-to-mouth behaviors is a risk factor. Next slide. So children who live in high-risk zip codes should all be tested at their 1 and 2 year visits, and all children insured under Medicaid should also be tested at those visits. And this is a matter of state and federal law. More targeted testing can be appropriate in children ages 3 to 6 who are high risk. And some of the common risk factors that we might see is pre-1950 housing, recent renovation to any housing built before 1978, and then clinical suspicion of lead exposure, a sibling who's lead poisoned, for example. Next slide, please. As Dr. Newman shared in our first session, there are some really unique considerations that are coming to light during the COVID-19 pandemic. And certainly we're all experiencing this extraordinary time, and many of us are in the trenches of the COVID response. One of the things that is coming to light with children who are at risk for lead poisoning is that, number one, the disparities in access to safe housing are certainly being highlighted during this time as people are quarantined in their homes. So children who don't have safe home environments are at high risk at this time, not only from lead exposure, but there are children who don't have access to safe drinking water. So those issues around safe housing are being highlighted at this time. And then also there have been delays in primary care with physical distancing measures in place. Some of it by design, with practices not able to see patients in person. Now that those in-person visits are again being reinstated, certainly issues around reconnecting with families, anxiety on families' part in coming back to resume primary care. And we've seen a precipitous decline in lead testing during this period. So we're probably under-diagnosing children with lead poisoning during this time, just as we're also delaying primary care in general, which is disrupting our ability to meet those kids' developmental needs, to administer vaccines, and do all the other things we do during primary care. So having a close relationship with a medical home is especially important during this time, because that's the way we're able to reconnect with children and get them sort of back in for the care they need. Next slide, please. As a reminder, this is a visual of high-risk zip codes, basically, in Ohio. So just a reminder that most of Ohio is considered high risk. If you will advance, most of Ohio is considered high risk. So most of us are practicing in or near a high-risk zip code. Next slide, please. Again, to review, blood lead testing can be accomplished through a finger stick capillary draw or a venous draw. We reviewed that some of the point of care testing technology can have less precision. So the interpretation of results make it a little bit tricky. And anytime that there's a positive lead test through a capillary draw, a confirmation venous blood test is required. Next, please. Now we're going to get into the roles of clinicians and public health professionals in primary prevention of lead exposure, and then talk about screening and testing and response to positive tests. Next slide, please. We often think about the role of the clinician in terms of testing and treatment, but it's really important to emphasize that clinicians and primary care providers have a very important role to play in counseling around primary prevention as well. But we do also have responsibility for testing, reporting, and medical management. And we work hand in hand with our public health colleagues who are on the front lines of primary prevention, of case investigation when there are positive tests, continued tracking, making sure that we understand current data around distribution of elevated lead tests, and then enforcement of lead abatement interventions. Next slide. Yeah, thank you. You can advance. This graphic emphasizes opportunities for primary prevention by clinicians of harmful environmental exposures in our patients. And the text in red underscores some opportunities for primary prevention related to lead exposure. So even during the prenatal period, discussing safe home environment, potential occupational exposures, potential exposures due to water when mixing formula, the benefits of breastfeeding. Lead paint exposure is something that we counsel about during infant visits, especially as children are starting to become more mobile. They're on the floor, they're getting ready to crawl, which is why we highlighted the 6-month visit. That's sort of right when that transition is about to take place. And then even for older children, thinking about arts and crafts, materials, potentially jewelry, toys, and then not to forget that occupational exposures can affect our adolescent patients and hobbies such as indoor firing range activities. Next slide. Next slide. So to review some of the main points around primary prevention that are relevant to clinicians, talking to families about avoiding lead contamination in housing. Resources around registries for lead-safe housing vary by municipality. We have some resources in Cleveland that help families to identify where there have been lead hazards identified if they're considering moving to a home. There are rental registries either in place or under development in many cities, reminding families about using EPA renovation, repair, and painting rule guidance in homes that are built prior to 1978. Reinforcement about the importance of a good diet, iron sufficiency, calcium sufficiency, and vitamin C sufficiency are all really important. And then again, the reminder to use EPA guidelines when doing renovation, repair, and painting. Next slide, please. This slide illustrates that the level of concern or reference level for lead in the blood has come down. But the important take-home point really is that there's no safe level of lead. So it's important to understand what that reference level really means. It's not a diagnostic level where below 5 allows us to prognosticate in a specific way around that child's symptoms later in life, and then above 5 also has some sort of like specific prognostic value, and it doesn't mean that below 5 is okay. So there's really the only safe level of lead is 0. And so we'll talk a little bit more about how our language around this has changed and what it means. Next slide. So instead of describing the reference level of lead as a level of concern, which implies that above the level is concerning and below the level is not concerning, we call it a reference value. And the way the reference value is identified is based on the National NHANES survey, which looks at lead levels across the country. And then the reference level is a level circled here. It's like 2 standard deviations beyond the mean, where 97.5% of kids have levels below that reference level. So it's really a statistical point. It's 5 micrograms per deciliter now. When I was a resident, it was 10. It may very well be adjusted downward as the total prevalence of elevated blood levels goes down. Ironically and sadly, the funding for primary prevention through the CDC has gone down as the reference level has gone down. So while there are, in fact, the same year in 2012 that the reference level was adjusted downward to 5, the budget for prevention programs was cut dramatically. That's why sometimes we hear described that primary prevention isn't practicable because there are inadequate resources for primary prevention to be accomplished through the programs that are in place federally. So a lot of times the role for primary prevention really does fall on clinicians and local health departments. And then too often we're more in the second and tertiary prevention domain when kids have already been exposed. That's important to understand both in terms of our role as primary care providers and frontline public health professionals, but also an opportunity for advocacy because primary prevention is ultimately our goal. And despite the recommendations around the reference level, the funding has continued to go down and down and down to accomplish primary prevention. Next slide, please. We reviewed in our previous session that while acute symptomatic lead poisoning is uncommon, these are some of the symptoms that you might see in patients with acute lead poisoning: abdominal pain, changes in mental status, headache, changes in gait, changes in speech, extreme fatigue. Next slide, please. Ultimately, what's the treatment for lead exposure? If you have an acutely poisoned child, like a child who exhibits some of the symptoms in the previous slide, who has extremely high blood lead levels, those children may need treatment in the hospital. They may need what's called chelation, and Dr. Newman's going to talk about that a little bit later. But for most kids we see with elevated blood lead levels, the treatment is to stop the exposure and to optimize nutrition. So make sure they have a safe place to live, optimize their nutrition. We'll talk a little bit about developmental and educational supports as well. Next slide, please. Next, we're going to spend a little time reviewing medical management guidelines. And we'll do that by reviewing guidelines for each category of elevated blood lead levels. So first of all, it's important to know that for children with a lead level of less than 5, it doesn't mean that we just say, you know, if it was over 5, it would be concerning. Less than 5, we're fine with that. There's still a need to review non-zero lead levels with families. Be aware that the geometric mean for blood lead levels for children in the United States is less than 2. So if it's non-zero, it's something that should still be discussed. Reviewing what are the sources for exposure, reviewing things like hand washing and sort of wet mopping, cleaning, looking for sources of lead exposure in the home, optimizing nutrition, and make sure that if children are at risk for nutritional insufficiencies, especially iron deficiencies, that we're addressing those. Next slide, please. After each one of these slides where we review guidelines for each blood lead level, we're just going to have an image here to make sure that you all are familiar with how the Ohio Department of Health's medical management guidelines visual looks. So the information here is the same as what I just discussed, but just so you kind of have a sense for what it looks like, so it's familiar if you are able to go and check out those resources on the ODH website. Next slide. For lead levels between 5 and 9 micrograms per deciliter, you're still going to review all of the anticipatory guidance and prevention counseling for below 5. If it was a capillary sample, you're going to confirm with a venous draw within the next 1 to 3 months. These levels get reported to the health department. Careful environmental history needs to be done to identify potential sources of exposure. Again, nutrition, which we talked about before. Some kids, so we test for anemia at the 1 and 2 year visit as well, and there may be additional iron studies indicated for the AAP guidelines. And the other thing to know is that now in the state of Ohio, any child with a lead level of 5 micrograms per deciliter or higher is automatically eligible for early intervention services. This is a change within the past year. And what automatic eligibility means is that even if children don't have current signs of developmental delay, which a lot of kids are not, if the primary reason for referral is an elevated lead level, even if they don't have current signs of developmental delay, they are still eligible for services, which isn't the case if you don't meet automatic eligibility. And the early intervention programs in our state are adding programs and services to support the needs of kids with elevated blood lead levels, including more of a robust social work program to help families to prevent ongoing exposure. Next slide. For blood lead levels between 10 and 44, you're going to do all the things that that we discussed in the previous slides, confirming again with a venous sample if a capillary draw was the original source, and then additional evaluation based on the history and environmental information. I want to make sure that everyone knows that the pediatric environmental health specialty units are an important resource to guide clinical practice in terms of environmental history taking, potential need for medical treatment, ongoing follow-up for these patients. And then if you go to the next slide, this has a little bit more information similar to the previous slide, but again, this is from the ODH medical management guidelines visual. And as you can see, there's some specifics about additional workup that might be required. So for example, if lead paint chip ingestion is suspected, then we would get an abdominal x-ray on kids with these higher blood lead levels. And kids would maybe need to be treated with a bowel decontamination if that's found. And I think everything else we discussed in the previous slide. Next slide, please. For children with lead levels above 44, we'll do everything that we covered in the previous slides. They need to have a confirmatory test done within the next 24 to 48 hours, and they may require hospitalization and chelation therapy. And again, the regional PACU, Pediatric Environmental Health Specialty Unit, or Poison Control Center can assist in managing those patients. Next slide, please. Same information as the slide before from ODH. And then the next slide, I think, is where I turn it over to Dr. Newman to talk a little bit more about chelation.
Hello, hi. Just had to unmute myself there. Yeah, we're going to talk a little bit about chelating agents in general, and then chelation itself. So chelating agents, like the very first agent was actually developed as an weapon of mass destruction agent. So like old BAL, like people may remember from residency, British anti-Lewisite was developed by the British to bind arsine gas, which they thought the Germans would be dropping on the cities of England during World War II. Luckily, that never came to pass. However, the chelating agent was developed. And so overall, the chelating agents are basically medications designed to bind usually divalent cations and improve their solubility. Because in truth, I mean, the reason that like lead was used as a in pipes and in paint is that it tends to resist dissolving in water. But under certain circumstances, you can promote it to be more water soluble. So that's what these chemicals do. And so this increases the load of lead going through the kidney. And the problem with it is they're not completely specific for lead. So they may grab other ions and other metals on the way out. And so that's not always all that great. There is a known toxicity to the bone marrow, liver, and kidney, and truthfully, like the uses are quite limited. There's a good we talked about the PACU a little bit, the Pediatric Environmental Health Specialty Unit. I'm for Ohio, I'm the representative for the PACU network. And there are a lot of like non-evidence-based uses of chelating agents. And if you look at the list of things that could possibly go wrong, I don't know that it's a good idea to be using these for anything other than what they were intended. Next slide, please. So what's interesting, and these questions come up, like, why do we only do chelation when the lead level is 45 or above? Well, there actually was a double-blinded, placebo-controlled, randomized controlled trial looking at Suxamer to see if it was effective for children with lead levels between 20 and 44. And they followed these patients out to 7 years and did not find any benefit neurodevelopmentally to the kids who were treated. There was a transient decrease in the blood levels in the treatment group that was higher than the decrease in the children in the placebo group, but the blood levels were not significantly different a year later. And I'll talk a little bit about like that in a minute because that intuitively might not make sense, right? But and the reason that they carried this out was like, so at that point in time, this was the probably late 90s. The Suxamer was on the available, and Suxamer is an oral chelating agent, and so you didn't have to inject people, you didn't have to have them in for IV therapy. So the thought was that this potentially could be misused by in a whole bunch of different circumstances. And the reason they did the study was that there were animal studies that suggested that Suxamer itself might be neurotoxic, so it was given to animals, and they found that the non-lead exposed animals did more poorly on the neurodevelopmental testing than the lead exposed but untreated animals. And it's we intentionally, I haven't included any dosages or anything like that, because really the chelation is not done very often anymore, and and so it's best handled with the help of someone who's experienced doing it. And I mean, currently, I have and typically I'll have a patient or two on chelation, particularly in the summer. And when you consider how many patients are in our catchment area, that's really not a lot. So the PACEs and the poison control centers are there to help you. I think what's really important to know is that the treatment is basically in order. You have to stop the exposure, because no amount of chelation is going to get lead out if the child is still being exposed. And so really there's no point. I mean, the main treatment is to stop the exposure. I can't stress that enough. Next slide, please. So the question is, why is it that the low level came down in that study, but then at a year they were about the same? And it has to do with how lead kind of works through the body. And basically, we measure lead in blood, and it's in basically a balance between the blood, the bone, the kidney, where some of it's getting excreted, the brain, and all the other organs. And so, but the half-life of lead in the blood is about a month. So, when I've had patients who were exposed, let's say, to a fishing sinker, and that was the only source in the house, and they remove it, their lead level might be 30 or 40 to start, but within a month, it drops very, very quickly, because there's only been that one source we eliminated. But for people who are exposed for a longer period of time, the lead deposits in the bone, and the bone then becomes a repository that then redistributes lead back out. So if you remove lead from the blood, it tries to find, water finds its own level, as they say, so the lead is trying to find its own level, and it re-equilibrates so that some of that comes back out of the bone, fills up the blood compartment with lead, and then it's able to get to all the other organs of the body. So, this is something that's seen very commonly when you're chelating children, because you remove the lead from the blood actually quite efficiently. But unfortunately, if there's a lot in the bone, it just refills it, essentially. So it sometimes can take multiple rounds of chelation to actually get the lead level to stop going up for kids who are chronically exposed to high levels. And we think that part of the toxicity of lead is based on the fact that there is this ongoing exposure. It's not just a one-time poison and you're done. It sticks around your body and it gets redistributed throughout your lifetime. Next slide, please. So I've talked a bit about like what the medical side of lead management is. And I think it's also important to talk about what does public health do. So it really is a partnership, and I think like maybe this isn't always completely appreciated. And so public health is involved with education, primary prevention, but they're also involved with trying to find the sources. So public health, when they and we'll talk about this a little bit, they do public health led risk investigations, and they'll try to determine like what the source is. I mean, maybe it's the house, maybe it's not, maybe it's dad's work, maybe it's mom's work, maybe it's some food product, maybe it's a toy, maybe it's a piece of furniture. So that's their job to figure that out. And then if there are lead hazards found, it's the job of public health to enforce that. And I think part of our job on the pediatric side is to have families understand that there is like a whole system that's working to try to deal with this problem. Next slide, please. So public health will respond to any venous blood lead level that's 5 or above. And so I'm just using an example 5 to 9, which that's the most common range that you're going to encounter. So the public health department will either, at the very least, will perform a phone triage where they'll ask a comprehensive questionnaire about potential sources, and they'll talk to the family about what resources might be available to them based on where they live in the state, because it does vary a bit. And I put up here just as an example, because I'm based in Cincinnati, the Cincinnati Health Department has what they call a, quote, primary prevention program, which is to try to prevent kids from having a lead level that's higher than 9. And this consists of, initial phone contact, and then a public health nurse visits the house twice. That's the plan. And during that visit performs, some very basic, like walking around with the family, looking for possible sources, doing a little healthy homes assessment of the house, providing a nutritional, developmental, environmental screening, and then education around all of those topics. And then we also collect, the nurse in Cincinnati also collects a water sample, which gets sent to the waterworks for analysis. And then they're providing some cleaning materials to try to reduce the lead dust burden in the home. Next slide, please. So lead levels that are 10 or above prompts a public health lead risk assessment. And so this is done by a licensed lead risk assessor. And it's their job to try to determine, based on the history, where are the lead hazards most likely to come from. And so, it starts with a history, and then they often start at the top of the house and work their way down. And they go in each room. And what I've shown here is a photo of an XRF machine. So this is a portable device that the inspectors carry with them, and they aim it at the item, whether it be a windowsill, wall, trim, toy, whatever, and they zap it. And on the display, it reads out instantly like how much lead is in that item. And for paint, let's say, lead paint was phased out in 1978, but houses that are 100 years old are going to have a lot of paint layers underneath, and this device is able to read through multiple layers of paint. So it'll tell the inspector, oh, okay, well, this window does have lead paint in it. And so where they're kind of screening with the XRF then leads them to where they collect the dust wipe samples, because how children get exposed to lead is mostly through ingestion. And so, and mostly through dust. And then there's a nurse involved, often at the local health department, if the Ohio Department of Health is performing the inspection, that does the case management, follows up with the family, try to help them get all the resources they need, and then helps them navigate the system, and to provide education as well. Typically, It takes about a month or so from the time the risk assessment is done until like all the reports and analyses are complete. Next slide, please. And according to state law, if let's say if the property is found to have lead hazards, let's say, you know, the windows are old and the paint is deteriorated and they contain a significant amount of paint, lead paint, and there's dust present that's, you know, coming from that window, then it's the responsibility of the property owner to fix the problem. And it needs to be done according to health department approved methods. You can't just like rip stuff out and, you know, cause all kinds of problems. It needs to be done in a way that is safe for the families, and that includes that the you know, the family can't be there while they're doing it because it'll stir up a ton of dust. Houses that are not abated in a year, the Fire Department puts them on kind of the bad list, which is the order to vacate list. A lot of and it isn't just like, oh, 90 days and then you don't hear anything for a year. I mean, there's a lot of checking in, and there's a lot of trying to get things done and trying to get people connected to resources. So there is an SCHIP lead abatement grant, which is funded through with help from the Ohio Medicaid program. There's also a middle income grant, as well as multiple HUD and other lead abatement grants around the state, which individual municipalities or counties or regions may have applied for and have funding for. Those are generally directed towards low income residents. And overall, like, the purpose of these grants is to maintain safe and affordable housing. And you know, people say, well, why don't we just tear them down and replace them? Well, yes, but if you look at how the reality of how real estate works, an older house is torn down and it's replaced with something that's much more expensive and well, more profitable to help, like, you know, pay for the cost of doing that work. So the purpose of these programs is to help families be able to, and help to maintain neighborhoods in that are affordable and safe. And finally, there's a lead tax credit, which higher income homeowners can access to help reimburse them for some of the costs associated with lead inspection, abatement, reinspection, et cetera. And the process that we call to get rid of the lead hazards is called abatement. Next slide, please. So I just want to walk through a clinical scenario. I mean, in my practice, where, you know, I see mostly it's environmental health, but there is some primary care. And I was a practicing primary care physician in private practice for several years before I came to academia. I just want to kind of like, I kind of pulled together an illustrative case of Timmy, you know, who comes in for his 12-month well visit. And, you know, this is not an unusual situation. You know, he lives in an apartment with his mom and 2 siblings. Mom doesn't know how old the building is. So, like, you ask them, oh, is it built before 1950? And most people honestly don't know. When I've talked to families, they'll say, oh yeah, you know, it's pretty old. Maybe it was built in 1960. And I look it up on the auditor's website, and the house was built in 1820. So there's a big difference between 1960 and 1820. And so for a lot of people, it's not obvious to them. People who own the houses often know how old they are, but she doesn't know the age. He visits with his dad, who works in construction, and lives in a building that mom thinks is older, with dad's mom, the paternal grandmother. Mom goes to school, and while mom's in school, Timmy attends daycare at a licensed daycare center, and he's insured by Medicaid. And the question is, does Timmy need a blood level? And the answer is a resounding yes. All right, thank you, Latoya, who just sent something in. Yes, Timmy needs a blood level. Next slide, please. So if nothing else, like, he's insured by Medicaid, and that's required by state law. That's like a shoo-in. But also, like, we put on there, like, if there's a clinical suspicion, then it should be checked. So the father's occupation and housing are possible sources of lead as well. I mean, construction is a high risk occupation. And I've had kids who the only source of lead was their dad's work that they would bring home, and the kid's lead level was 30. And so it's not impossible to bring home enough lead to raise a child's lead level. So his lead level comes back at 7.5. And so the local health department contacted mom and provided her some information about wet cleaning surfaces and encouraging iron-rich food and discouraging oral behaviors, and to get a follow-up level in about 3 months. So you say to yourself, but like, you know, with 12 months, oral behaviors are normal. And you know, so, you know, you can make some substitutions. You know, there's a lot of things that you can, distracting children, et cetera, giving them other things to play with that you know are clean, for instance, versus something that's just been rolling around on the floor for a while. So at 15 months, Timmy comes back, and mom has been cleaning the home twice a week. Dad's been changing his clothes before playing with Timmy. And since, you know, if you look in the 5 to 9 range, it suggests, you know, exploring iron status according to the AAP guidelines. So this particular group got a CBC, ferritin, and C-reactive protein. You get the C-reactive protein with the ferritin because they're both acute phase reactants. And according to the guidelines, and I've seen this clinically, it takes very little to raise your ferritin level in terms of like a recent illness or anything like that. We think where it's available, reticulocyte hemoglobin is also a very good indicator of iron stores. And perhaps is less affected by acute illnesses. And so might be a good test if, you know, because it can be run with the CBC depending on how your lab works. Our lab recently added this to their armamentarium. So the lead level was 12, hemoglobin was 10.8. So not like extremely low or worrisome, but something that needs to be addressed. And ferritin is 5, which is low for their lab, and the CRP was normal. Next slide. So because the lead level is over 10, the Ohio Department of Health performed a lead risk assessment at the home. It turns out mom's home was built in 1919. You can find the age of homes actually on the county auditor's websites. I do this pretty routinely because it helps us to risk stratify the patients a little bit and help us figure out where things are coming from. The inspector found lead hazards on the windows and trim, and then high lead dust levels on the floor. So like the XRF was positive on the windows and trim, and high dust levels on the floor near there. The reason, you know, that windows and trim are such a problem is, like I said before, lead resists dissolving in water, and lead paint was actually pretty expensive back in the day. So people, you know, saved it for the places that needed it the most. So high traffic areas, areas that were going to be moist or wet. There was also some water damage from an old roof leak, and some of the plaster was bubbling, so that if there was, that's another like source of lead dust coming from, you know, old painted plaster. There's also bare soil in the backyard where he plays. He drinks an excessive amount of cow's milk. Dad's home, it turns out, was built in 1967 and was completely renovated in the 90s. And Dad only works in new construction. So like in terms of a source, it wasn't Dad, although in some situations, like, you know, this would be like the complete opposite. But the only way you find out like what all the, you know, where the source is you actually have to find out where the source is, you actually have to find out where the source is. Like, so you have to have a professional who knows what they're doing actually go out and figure it out. So what other actions might we take at this point? Well, next slide, please. Like iron supplementation is recommended. Low iron stores are likely to increase lead absorption. So that's one mechanism, because they both share the same divalent metal transporter in the bowel. Um, Low iron is also associated with, on itself, with developmental delays. And it's been known that uh, children who are, and lead and low iron are kind of synergistically bad. So like low iron is bad and high lead is bad, and low iron and high lead together are actually doubly bad. So we want to try to address these things in terms of mitigating risk factors for future neurodevelopmental problems. We talked about reinforcing some temporary measures to address the lead hazards. You know, if there's an area where there's obvious deteriorating paint, don't mess with it. You can cover up with tape until you can get somebody to fix it. At least that buys you a little bit of time. You know, we suggested avoiding the soil in the backyard, playing back there, maybe playing at a park or maybe in the front yard where maybe it's not, the yard's in better shape. And the repeat lead level was needed in about a month. So like talking points, I mean, like, you know, before testing, I mean, I think it's important for parents to know why this is being done. I mean, lead poisoning, and we, since no level's safe, like we're kind of thinking just like almost any amount is poisoned, although there's certainly a quantitative and qualitative difference between the kids who are ataxic and the kids who have, you know, basically subclinical lead poisoning. But it's a, you know, it's a common but preventable cause of learning disability and behavior problems in children. And we've talked about how it affects IQ and it affects impulse control. And no blood lead concentration considered safe. And it's the law that the kids need to be tested if they live in high-risk areas or they have Medicaid. Unfortunately, only about half the kids are being tested that are high risk. And, you know, people worry like, well, what's going to happen if it turns out that there's issues with the house? I mean, it's not perfect, but we have a lot more resources now to help families deal with problems with housing than we've had in recent memory. And so it's worth using these resources where we can and using them appropriately. And, you know, also to think children with iron deficiency absorb lead more easily than children with normal iron. So, you know, afterwards, like just to think about, like in the United States, I know we had said it was under 2. The blood concentration is about 1 right now for kids under 6. So if you have a kid with a 5, that's like 5 times practically higher than the average for the country. So, you know, if someone's, I don't know, blood pressure was 5 times higher than the average, people would react to it. And I think, not that it ever, you know, it couldn't be, obviously, but you know, the point I'm trying to illustrate is that since there's not a safe level, and we see that the effects even happen at low levels, the time to intervene is when it's low and trying to do something about it. Because a lot of the kids that I see who come in later to my clinic with a lead level of 100 started with a lead level of 5 at one point. And, you know, sometimes the families don't follow up or something doesn't get done right, but, or it's just, you know, just bad luck. But, you know, the time to intervene is when it's lower. And obviously the local health departments and our offices will help them. Although we can't reverse the neurodevelopmental effects of lead poisoning, I like to stress the fact that lead really is a risk factor for problems to happen later. Just like, well, high blood pressure is a risk factor for having a myocardial infarction or a heart attack. So yeah, you have high blood pressure. We're going to do something to deal with your blood pressure. And we're going to try to do some things to try to mitigate some of the other risk factors that you might have. Like, okay, well, let's see what we can do to try to help get your diabetes better under control. Or what can we do to try to improve your diet or improve your exercise? I mean, you know, this is all like trying to adjust risk, because the risk, you know, getting exposed to lead, it's not a 100% risk that something bad is going to happen. It increases the risk, but it's risks that we can modify. And the other thing is that the studies suggest that it isn't just like, and I talked about this, I think the last time, it isn't just like how high the lead level is, but how long it stays high. So, you know, the lead level that predicted best how kids would perform in school or whether they would get in trouble as they get older was really what their lead level was at around school age and not necessarily what it was at 1 or 2. So that, you know, at school age, you know, 7 years old or whatever, that tells you like what that child's been exposed to those whole 7 years. So if we can minimize that, then we have less exposure, and that's what we're trying to do. Next slide, please. So we put together a little flow chart, which was really meant not so much for the slide set, but more for to make it more operational and you know, on the boots on the ground. And this would be part of a, I mean, this could be used for the quality improvement project that we were talking about, but also like it can be used in general. And, you know, part of it is a decision making, like who needs to get a lead level, what is the level, what do you do with it following. So just a real brief summary so that you know where to go next. Next slide. So in summary, and it sounds like we keep saying this over and over again, but lead testing is required for all high-risk children in Ohio at 1 and 2 years. And the definition of high risk is based on whether they have Medicaid insurance or whether they live in a high-risk zip code. And as Dr. Boll pointed out, almost the whole state is considered high-risk zip code, except for probably the exurbs of the major cities where you have a lot of very new housing. But you could see there's a lot of rural areas that are on there. The urban areas we couldn't zoom in on, but like they're extremely high, a lot of them. We prefer primary prevention of lead exposure. And, you know, from a pediatrician's perspective, that it means delivering anticipatory guidance. And we provided some of that here. And there's more on the Ohio AAP website. Secondary, tertiary prevention, basically, we need to stop the exposure. After the kids have been exposed, we need to stop the exposure. Address the risk factors, and then medical chelation really should only be done with the help of an experienced practitioner. I get calls and, you know, people want to start, oh, well, what's the dose of whatever? Because we're, you know, I'm seeing this kid and I want to send him home. I'm like, well, where's the lead coming from? Well, I don't know. We just need to get it down. I said, well, we need to get him somewhere where there isn't any lead first, and then we can get it down. And then we can talk about like what the medical management should be. And so, you know, I think given what we've talked about, some of the side effects of these chelating agents, particularly even potential effects on the brain, we want to use these very carefully and only in situations where they're clearly indicated. So next slide. So I really want to thank you for the people who've stuck through 2 of these presentations, for participating with us. We're here for questions now, as Alex said, to put them in the chat box, and then you can obviously check out some stuff through the Ohio AAP website. So thanks very much for your attention. We really appreciate this. Thank you.
Yeah, thank you. Thank you, Dr. Boll and Dr. Newman, for speaking, and thank you again to the Ohio Department of Health for their resources and collaboration with these trainings. So at this time, like Dr. Newman said, we will take questions, and you can enter those into the chat box, and then I will go over a few of our resources that are available. And like I said at the beginning of the training, you will receive a survey on Monday that you can fill out, and that is how you will receive your CME and MOC Part 2 certificate and credit, and credit for attendance as well. Let's see. And then there is a question in the chat box. It is, we have a point of care capillary lead machine. If the follow-up venous sample is less than 5, how much should we be worried that there is some lead surface contamination? How much should we encourage an inspection given that there is some lead in the child's environment?
So I'm happy to address that first if you want. So, you know, basically, if it comes back positive, that's suggesting that there's lead somewhere. the health department won't conduct any evaluations for lead levels under 5. So what I usually do is I'll sit with the family when there's questions about this, because often sometimes these kids will find their way to my clinic, but I will talk to them and just start to ask, like, what do you all do for a living? What, where does your child go? Were they at home all the time, or do they go to a daycare or another person's house? So you can start to try to figure out like what potential sources could be. I think, unfortunately, we didn't have the time to go into like a really in-depth like environmental history taking here, but I think that often there'll be some clues. I mean, you find, oh, well, their house was built in 1925. It's like, well, that kind of puts it up to the puts that up the list, and then you have to start to think, okay, well, what can we do to try to address things in that home, like either cleaning wise or maintenance wise, to try to reduce the risk. And it looks like there was some stuff added to the point of care machine only goes as low as 3.3. So, that's a good question. I think at this point in time, I think you do have to use some. I'm trying to, if clinically you get this feeling like, gosh, I think there's more going on here, then for sure, like, send them somewhere where they have a machine that has a lower threshold. But in truth, there's only so much resource that all of us have to follow up with this. Now, having said that, there's a very good chance that sometime the CDC will change what this reference level is to something lower. There has been some discussion of that. And until that time comes, I think a lot of practices are put in your position, Dr. Bunch, like just trying to figure out how to navigate like these, what's less than 3.3. Well, as far as you know, it could be 0, or it could be like 3.2, right? And part of that, partly a history may help you determine like how much concern you need to have. And the, if you have multiple that come back low, then that's also more reassuring. So like if you have a child who has a lot of oral behaviors, lives in an older house, you might say to yourself, well, maybe I'm going to do something like a little bit more enhanced screening for that kid. I mean, that's how I would approach it.
Just a couple other things to add. As far as encouraging inspection, I mean, depending on your location, that might be a little bit out of our hands. Like where I practice, there are resources for inspections for children with blood levels over 10, but not under 10. So it's really on me to provide counseling to that family. And so sometimes I also think about how would repeating the level or sending them to another lab change my management. And if I'm really going to be taking in a careful environmental health history, reinforcing preventive strategies, encouraging healthy nutrition and a stimulating environment for development, and that's what I would do even if I did send them to another location, for example, then I might not do that, and I would take the approach that Dr. Newman just articulated, which is to maybe take a little bit of a more sort of targeted approach to screening that particular child who might have some ongoing risk factors. So it's kind of like, number one, the inspection resources depend on where you're located and what your local health department can provide. And then number two, if it's not going to change my management, I may not send that child for another test. I'll just do that type of counseling and referral right there.
And then there's another question about what does it mean to say testing is required by law, required to be ordered by a physician, or parents are required to have their children tested. She does home nursing, visiting for families with children under age 3, and talk with families about importance of having their children tested, but was unaware of the law.
So the law requires, and I'm bad. Like the law is very specific about how it's worded. So like, don't, I mean, I know this is being recorded, but don't quote me exactly because I don't remember the exact wording. But the gist of it, as I recall, is that whoever provides primary care, so like physician, mid-level provider, et cetera, is expected to get these lead levels drawn. And so it starts with them obviously being ordered, yes. And there's actually been some communication that's gone out over the last like probably 2 to 3 years, I think, both from the Ohio Medical Board and the Ohio Department of Health, trying to stress to physicians that this is the law and it's supposed to be done. And I think part of the issue maybe, I mean, this is why we're doing this. The whole purpose of this like whole series and everything is the Ohio Department of Health is frankly concerned about what the testing rate is in the state among high-risk children, and this is an attempt to try to increase the testing rate. And so any way that we can get the message out that the law requires of this to be done, I think will make it easier to get it done, I would hope. And I think it's great that you're doing nurse home visits and you're talking to families about this. And I don't know what your, how you connect back to their medical home, but I mean, it could be a useful, if families are asking for these services, they're also more likely to happen. Do you know what I mean? So I think your work could be very important in helping to, there's a push and pull here to try to get any kind of, poking done on a little kid.
If I could briefly add, that's also my understanding about the law. It's for primary care providers, directed at primary care providers. And to just piggyback quickly on the role of a home visitor, for example, another barrier oftentimes for some of the public health interventions is if families don't feel comfortable having someone to come do the inspection, there's definitely sometimes some resistance. And so I think for us as primary care providers, we really have an important role to play in explaining that process, why it's important to develop some trust with families around why inviting that person into your home, it makes sense for the health of your child. And home visitors who have relationships with families like home nurses also have a really, really important role to play there. I'm not sure if we specifically covered that in our presentation, but we all encounter that all the time. And so that's a really important part of our counseling too. The next question I see just points out that that when discussing average lead concentration levels in children, emphasize that that there is an under-testing of high-risk children that that contributes to sort of understating what the average level is. So we are under-testing high-risk children. If we tested more high-risk children, the average level that we see in the population would potentially be higher. So the point just being made that we really emphasizing that high-risk children are under-tested, and that is a point well taken. It's true.
So about housing issues. I don't know, Dr. Boll, do you mind starting that? Because I'm looking at the next question.
So I'm sorry, I needed to scroll down. Can you talk more about what happens when there is a positive test and whether a family needs to move out of a rental property and becomes potentially homeless? Can you speak more to housing and what happens? Well, it depends on where the source of lead is discovered. So if the home is discovered to be unsafe for habitation, there are resources. It does vary a little bit by city how it works, but Dr. Newman reviewed some of the resources around abatement, but there are also resources that help families find temporary housing that is lead safe. So it sort of depends on the source of the exposure and whether vacating the property is required to avoid ongoing exposure. I've definitely had some patients where that's been needed and they've been placed in temporary housing. Certainly issues around fearfulness about housing insecurity, concerns about things like eviction and being able to obtain stable housing is a real challenge for families and can definitely be a barrier for for families, like, can maybe even make people feel fearful about getting tested and inviting people in to inspect. So it is definitely a challenge. I know here in Cleveland, we're doing a lot of work around making sure that there is primary prevention accomplished in housing remediation. But to your point, sometimes families do need to be placed in temporary housing if the house is not safe for habitation.
And the other thing I might add is, I mean, by law, they're not supposed to be thrown out because their child gets lead poisoned, but a lot of people have month-to-month leases, and the landlord's like, the moment there's a slight bump in the road, they're like, oh, I want this unit vacated, next month, and they're stuck. And like Dr. Bull said, there's a variety of resources depending on where you live in the state, and often, I mean, we lean pretty, and this is where like the PACU or the children's hospitals or other places sometimes can help you, because we'll lean on our social work support and stuff. And I've used our hospital's social work help for a lot of kids who are stuck in this type of situation. Not that we have like a whole bunch of magical housing to get them into, but often they just need help navigating this system, because, I keep getting back to blood pressure, but like if your blood pressure came back high, they wouldn't say you need to move out of your house. You know what I mean? Like this, like the blood level comes back high, and then all of a sudden, like you don't have somewhere to live, or like your housing becomes like a problem. So, so let me look. If the child's blood level is high, 44 or higher, they've been exposed for a long time. How long will it take to be exposed for them to have irreversible bone marrow damage? Oh, okay. So let me explain a little bit. Maybe that didn't come across clearly. So the lead itself is, I mean, it does affect the blood system, but we don't, there's no, so the chelating drugs can be damaged, it can be harmful for the bone marrow, but we monitor the kids while they're on chelation, and we've never, I mean, we're never going to have to do like a bone marrow transplant because for that reason. The effect on the bone marrow from the chelating drugs, which is mostly what we're worried about, that reverses when you stop them. So often like within hours. So we don't worry about that. The lead stays in the bone, and it does have, but it's not in the marrow of the bone. It's in like the hard part of the bone, and so because it sits where the calcium does. And so what we believe, for the most part, when it's in there, it's not affecting the other parts of the body. There is a study that's just finishing up down here in Cincinnati, looking at people who were infants when they were tested for lead back in the 70s and 80s, and now are in their 30s and 40s. And looking at what the long-term effect of the lead in the bone has done. And so that stuff hasn't been published yet, so we don't know what it's all about, but I hope that answers the question. So like lead is bad, but it stays in the bone, and mostly we think the badness from lead, like in terms of the organs it affects, I mean, it affects all the organs, but the organs that are affected probably the most are the brain, the kidney, and then the cardiovascular system. But like that's a pretty deep like set of weeds to get into. So hope that answers that question. Great.
Okay, great. At this time, are there any other questions? I think we have time for maybe one more because we're close to the end.
So if I might just say something for a second. So, I mean, if you do get into around this lead thing, I know the folks in the Cincinnati area, I get called from quite a bit, but if feel free to use your poison control or use the PACU network when you run into things like this and you're not sure like what the right next course of action is. And the two are kind of complementary, whereas, the poison control is really set up for like acute poisonings, and the PACU is set up for these like chronic problems and exposures that go on for a while. And like, how do we sort this out, and what's the best management, and how do we try to mitigate and deal with things. So they have complementary roles, and I work pretty closely. We have a poison control center down in Cincinnati, and I work pretty closely with them. And so they'll often direct cases to me that aren't an acute poisoning, but someone needs to understand what's going on around lead or some other environmental exposure. So I don't know if it's all Ohio people on here or not, but I mean, I'm kind of, one of the resources in Ohio. But if there's people out of state, the PACU network is national, so it is a resource for the whole country.
Oh, great.
I would echo that. A lot of times people are not aware that the PACU network is a resource. So for us in Northern Ohio, all over the state, and even nationally, the link is on the Ohio AAP, or it's pacu.net.
Great. Thank you, Dr. Bull and Dr. Newman. I know I covered this in part 1, but I also wanted to review the resources that we have available. Again, we have our interactive website with resources for providers, families, and then you can also sign up for our QI program. You can view the part 1 training, and we'll have part 2 up there as well. And then we have this is a copy of the family RAC card, and then the resource guide for physicians. And you can access them on our website at any time. And then if you have any questions or comments that you would like answered, feel free to email me or call. You can also connect to the Ohio Chapter American Academy of Pediatrics on Facebook, Twitter, Instagram, or use our website. And if anything comes up or any questions that you think of, please feel free to shoot me an email. Again, we want to thank Dr. Bull and Dr. Newman for their time, and as well as ODH for their support for these trainings. Thank you everyone for joining us today, and we hope that you will join us in the future for more trainings or participate in our QI program. Have a great rest of your day.
Bye, Dr. Finn.
Bye.
It's Karen Perez.